Good morning, everybody. It is my pleasure to introduce this morning's speaker, Dr. Brook. I'm one of the only people in this room who actually pronounces his first name accurately. And I want to tell you a brief story. When I just finished medical school, just finished my internship, and I was going over the literature, and Itzhak knows this story, going over the literature, I came across an article about, a review article about anaerobic infections in children. And I couldn't get it in the library there. So in those days, unlike now, you couldn't get it through the internet, of course. I had to fill out this card, and the card was mailed to the United States. And not long after that, I got a letter in the mail with a copy of that review article with a little greeting from Itzhak. And little did I know I'll be working with him when I came to Washington many years later. So this was as far back as then. So Itzhak Brook is an adjunct professor of pediatrics at Georgetown University in Washington. He's a pediatric infectious disease specialist who has had many accomplishments in his career, including past chairman of the Anti-Infective Drug Advisory Committee of the FDA, and has done extensive research, published 128 book chapters and 6 medical textbooks, many articles, and he is also on the editorial board of Head and Neck Cancer Alliance. Dr. Brook is the recipient of the 2012 Conley Medical Ethics Award by the American Academy of Otolaryngology, and is the author of the books My Voice, A Physician Personal Experience with Throat Cancer, and I think in some other books. And this particular book describes his personal experience as a physician experiencing medical care, and as you can imagine from the title of today's lecture, medical error. So he will share with you what it's like as a physician to be subjected to medical error. And individuals can respond to medical errors in many different ways, lawsuits, etc. Dr. Brook has chosen to use his personal experience to teach others how to prevent and how to avoid medical errors, and we applaud him for it, and today he's going to speak to us about that.
Good morning. It's a pleasure to be here today and speak to you about a very, very personal story in my own journey in dealing with medical errors in my treatment as a patient. It's a rather unusual topic, especially speaking as an adult patient to a pediatric department. The last time I gave grand rounds here, 8 years ago, I spoke about sinusitis. But this is an important topic, especially for pediatric, because children are voiceless like I was when I became a patient. And we as pediatricians have the obligation to do as much as possible to prevent medical errors. A few words about the way you hear my voice. I underwent laryngectomy more than 6 us with the process of healing after everything, not just surgery. Well, let me share with you some examples of the medical errors that happened to me. After my initial cancer was diagnosed, I had a very, very minimal lesion
Thank you, Dr. Brook. I'm sure that a lot of people in the crowd here are very moved by this presentation, and hopefully it is going to have the impact that it intends to have. Any questions?
Dr. Brooks, excellent presentation, and you really touched on what we all physicians and providers should be sensitive. I think nowadays, in the 21st century, we are really relying on technology. We are becoming computer people oriented. We are losing the fact that a physician is a person who has to take care not only of the disease, but the whole person, and to be sensitive and to be attentive. I think that I also wanted to mention, I went to so many presentations. I think your presentation today was the most easy to understand, well spoken, and I understood every single word that you mentioned. So thank you so much. The other thing that these are good points that you're making. I think probably one has to look at the reason why this is happening. As you mentioned, the factor time is an important issue. Fatigue and time can certainly have a major impact. And the way that things are going with these changes in the field of healthcare, we are seeing less and less time allowed to us to see patients, and this probably might even increase expenses in healthcare due to errors and missing diagnoses and misdiagnoses as well. You mentioned about surgeons. Surgeons are fun to be with. They are very interesting people. And you mentioned educating surgeons. I think it's not something very easy because, as you know, these people have a certain ego. And sometimes they think that they are the people that master everything. So this is something that should be looked at during the training of a surgeon, for them to be very sensitive to that as well. And a last comment to support what we are saying. I had a personal friend of mine came out with a certain type of cancer, also related to the laryngeal pharyngeal area. And I went with my friend to 4 different institutions, and the 4 different institutions gave completely different treatment plans. And so I think, number one, if anything serious will happen with our patients, our pediatric patients that require surgery, we are also responsible. A new paper just came out with the legal aspect that when we refer a patient to a specialist, we primary care, we are legally liable if things go bad. So we have to know who we are referring to and to follow up on what's going on. So having several opinions, number one, very important. But the most important thing when we select a specialist to do a sensitive type of operation or surgical procedure that could be sensitive, an important decision, it should be a physician who had intensive experience, who has been doing this many hundreds or thousands of times, no matter how many books he wrote or how many papers he published, and that's very important. Thank you.
I could not agree with you more. My first surgeon, the one who missed the cancer, I asked him, do you think you can do it? It was a day before. He looked me in the eye and he said, if I couldn't, I wouldn't do it. He was a very confident person, very skilled. And he told me, in surgery, you see one, you do one, you teach one. Now I would say, you see 200, you do 100, and you teach one. I was lucky that after the failures of what happened to me, I went to a second opinion in Philadelphia. And the surgeon there told me honestly, I am not able to help you. It's beyond my expertise. And he's a person who does it all the time. He said, what you have, I've never really done enough you said rarely, maybe 3 times a year. The surgeon in New York does it twice a week at least. So here is a difference.
Thank you, Dr. Brook. I just want to highlight a couple of things for the residents from your superb talk. One is when a patient comes back from the operating room, that they wake up helpless, dependent, and unable to communicate. I think that's very important for those of us who take care in the unit, patients with Lefort's or intubated. If your patient can communicate by writing, please try to have them be able to do something. Give them a piece of paper and a pen. Makes a huge difference. The other thing that you've highlighted so wonderfully is the fact that CT scans, PET scans, X-rays, and so on are just a snapshot of a window in time. And how staff learn very much more by dynamic attention to the patient. You guys are very lucky. You're actually in-house. We've lost that opportunity because we go home, and so we rely on your eyes and ears to go back. Please keep going back to look at the patient. But I just wanted to say thank you. This was absolutely marvelous talk. Thank you.
Thank you, Dr. Brook. As you know from rounding at Georgetown, the post-op care model is co-management by the surgical and either the PICU or the general peds team. But I was wondering, is there any literature on whether that increases safety or decreases morbidity in the post-op period? I know that's the model for most hospitals in England, that surgeons operate and doctors do the pre and post-op care. It's Mr. No, they are not.
I'm not really aware of any. I'm not really knowledgeable in this. I'm sorry, I cannot answer that question.
Just for everyone, just to add something about what's happening here at Georgetown, 'cause many of you know, but some may not know. Georgetown has embarked on a patient safety journey about 15 years ago, and is now finds itself in a position of one of the leaders in patient safety in the country. We have a Center for Patient Safety that is a multidisciplinary group that meets every week at 7 o'clock in the morning and represents leaders from from every aspect of care in this hospital. And we are collecting incident reports that are reported at very high rates from all aspects of care in this hospital. They are being analyzed and being acted on. We have a something called PFAC, which is a Patient and Family Quality and Safety Board that advises the hospital and the clinicians on issues just like that. Actually, I invited Dr. Brook to apply to join that board. Those are the individuals on the patient and family side are people just like Yitzhak who are trying to help the hospital realize what it looks like from the other side of the stethoscope, as he mentioned. And I think this is a great resource for all of us. So I think that there's a tremendous amount of effort being placed on patient safety, on putting in checklists, on improving care and improving all the aspects that you mentioned. And interestingly, surgeons have been a very integral part of this effort here in this hospital and have been present in all of those meetings, and they really are trying hard to improve safety. As a matter of fact, some of the patient safety movements started by operating room safety, where surgeons realize that a lot of errors that occur there may have significant important consequences. So there's a lot of effort in that regard. And I've been talking to Kristen here about the fact that we may be offering our residents a track, a patient safety track, which is an alternative track to the research track and the global medicine track that would enable them to be involved in initiatives and research related to patient safety. Any other?
Dr. Brook, while I was listening to beautiful, eloquent speech, it brings to my mind us as a physician, we are losing our human interaction with patients. Osler, the famous physician, says, listen to your patients. If you sit and listen to your patient for 90 minutes, for 15 minutes, 90% of the time, the patient will give you the diagnosis. By listening intensely to your talk, nobody listens to you. You already made your diagnosis from the beginning. Unfortunately, your physician did not listen to you, and they missed it. One big reason nowadays is, as Dr. Nusuli says, because we are all mostly thinking about technology. And this is very, very dangerous. We lose our human interaction. As Einstein says, which I am very fond of his writing and thinking, says, I am afraid one day the technology will surpass the human interaction. And at that day, we will have a generations of idiots. I hope that day has not come yet.
Any other comments? By the way, just one more thing, because we do have a minute. Dr. Donovan, the head of the Pellegrino Center for Clinical Ethics, is sitting here in the audience. One issue that we have discussed in the past is, it happens a lot in this country. An individual, surgeon or otherwise, finishes their training program and goes and opens up a new service in another hospital, in another city. And that person may be experiencing a situation where they are operating for the first time without supervision. And the question is, according to what you're saying, there's an ethical dilemma here. If they will publicize to everybody, hey guys, this is you are my first patient I'm ever going to do by myself, is that program will ever get going? So there is a balance here between those two. How do you close that gap? In everyday life, and Dr. Donovan and I have talked about it with Dr. Pellegrini when he was still alive, right outside here. What do you do when it's 2 o'clock in the morning and you're a pediatric resident and this is your first LP? And this is a child with suspected meningitis, and you want to reduce the likelihood of a bloody tap, right? Should the most experienced person be doing this? Should you be calling from home an experienced attending physician? Well, attending physicians no longer do those, so they may not be experienced, right? So maybe a chief resident or whoever has done this the most, a NICU fellow, how about that, okay? Call somebody who's done this, call Dr. Hauser, right? And Dr. Hauser has experience because he's done, hundreds of those during his residency because things were different. The residency hours were a little different. But the question is, should the most experienced person do it? And how would that affect resident training and residents getting experience? So if a child is having open heart surgery and there's a cardiac surgery fellow doing the case under the supervision of a more senior surgeon, is that the exact same expertise as the senior surgeon doing every suture by themselves? And how does that affect training programs? So there are broad questions that can be expanded from this particular discussion, and I think that we have a great opportunity here in the Center for Clinical Bioethics to take those issues and discuss them. Thank you very much.